holds curl pretty well.
Welcome to the New Orleans Humanist Perspective, presented by the New Orleans Secular Humanist Association, following a few principles of humanism.
We're committed to the use of science and reason for understanding the universe and for solving human problems. We're skeptical of untested claims of knowledge, but we're open to new ideas.
We are concerned with securing justice and fairness in society and in ending intolerance and discrimination. We are committed to the total separation of religion and government.
We affirm humanism as a realistic alternative to the theologies of despair and the ideologies of violence. We reject the concept of an afterlife and believe in living a full and rewarding life here and now.
We value and respect each individual's right to judge and lead their lives according to their own position, as long as it's respectful of other people living in a free society.
We hope you enjoy today's program and others in the weeks to follow.
Hello, and welcome to another edition of the New Orleans Humanist Perspective. My name is Charlotte Clausen, President of the Board of the New Orleans Secular Humanist Association, which is the sponsor of this program. And I'll be your host for today's show. We wanted to let our viewers know that Harry Greenberger, NOSHA's President Emeritus and longtime host of this show, passed away on Tuesday, May 2nd, just before midnight, while in short hospice care. He was a much beloved friend and mentor to many people in our community, and he will be so greatly missed. I wanted to dedicate today's program to him in his memory. Let me tell you a little about my guest, Sheryl Martin-Schild. Dr. Martin-Schild graduated from Tulane University School of Medicine while also obtaining her PhD in neuroscience. She completed a combined internal medicine and neurology residency, also at Tulane University School of Medicine, and a fellowship training in vascular neurology and clinical research in vascular neurology at the University of Texas Health Science Center in Houston, Texas. Dr. Martin-Schild started the stroke program at Tulane Medical Center in July 2008, where she directed the stroke research program, which participated in NIH-funded clinical trials and numerous investigator-initiated studies of stroke with an emphasis on racial disparities in outcome, access to stroke care, and stroke in the young. She advanced Tulane Medical Center to a primary stroke center level in less than 2 years from inception and a comprehensive stroke center 3 years later. Her service delivered the highest rate of and most efficient with thrombolytic treatment for ischemic stroke in Louisiana. And Dr. Martin-Schild now serves as the statewide stroke medical director for Louisiana Emergency Response Network, through which she is tasked with implementation of the stroke system of care, monitoring quality of acute stroke care, and stroke education for healthcare providers. She is the president and CEO of Dr. Brain Incorporated, which provides on-site stroke leadership and patient care to hospitals committed to improving or developing stroke programs. She currently serves as the medical director of neurology and stroke for Touro Infirmary and New Orleans East Hospital. I did want to make a note that Harry Greenberger suggested you as a guest for the program after he suffered a mild stroke back in January, and that it was when you met him, and he would be proud that we were finally able to make this happen, so I want to welcome you to the program.
Thank you for having me.
I thought we would start out with the simple question of what is a stroke?
A stroke is when there is disruption of blood flow to part of the brain. There's really two different forms of stroke. There's the kind of stroke when there's a broken blood vessel and there's bleeding into the brain tissue or into the fluid spaces around the brain. Or there's the kind where there's an obstruction to blood flow to part of the brain, and that part of the brain ends up with inadequate blood flow delivery, and brain cells start dying rapidly.
Okay. And how can someone tell if they are having a stroke or if someone with them is
It's a great question, and I think that that's one of the problems with getting people to recognize stroke and to initiate access to emergency care is that the stroke is actually happening in the brain itself, but the symptoms are manifested elsewhere. So the symptoms of stroke are basically any sudden loss of function, and that could be a stroke. The common ones are going to be any sudden weakness affecting one side of the body, and it could be the whole face, arm, and leg on one side of the body, or it might just be the face and the arm. It could just be a leg. But sudden onset of weakness on one side of the body is a stroke until proven otherwise. Another common symptom would be sudden numbness affecting one side of the body. Any sudden clumsiness or incoordination where you want to do something with a limb, but you're having trouble making it actually do what you want it to do. It might be clumsy and knock something over. Or you might have clumsiness of walking where you can't walk straight. You might be veering off to one side. That would be a symptom of stroke. Another one would be any communication problem, whether the speech is coming out slurred as if you're drunk and you're not, or if there's trouble expressing thoughts into words or understanding what somebody else says to you. That's another common symptom of stroke. And another one that is pretty common is vision. You might end up having loss of vision in one eye as if your eyelid's closed when it's not. You may have double vision where you see two objects and you know that there's only one. Or you might have trouble seeing on one side of the world. For example, if I hold my hands up and I wiggle them, if I could only see one hand wiggling, but they were both wiggling, that would be a sign of a stroke. So any of those represent sudden loss of function, that or a severe headache without a great explanation would be another sign of a stroke. So any of those or combination would represent possible stroke.
So like with a headache, it would be something that just suddenly happens? Is that how they
Stroke causes sudden loss of function. So in the case of that broken blood vessel, often, not always, but often there's severe headache, and then there might be loss of function depending on what part of the brain suddenly has this hematoma inside of it. Whereas with the ischemic kind of stroke, each part of the brain requires blood flow from a specific artery. Sometimes more than one can help out. But if the blood flow through that artery is suddenly cut off, then that part of the brain is like, where's my blood flow? And after it exceeds its already stored energy, it can't produce any more energy, and then the brain cells stop functioning. And what you see is whatever function that part of the brain had as its responsibility goes away. The problem is that when an arm suddenly goes weak, you think something's wrong with your arm. You may not understand that the reason your arm's not functioning properly is because you actually have a problem with blood flow to the brain. So it takes that key awareness that each part of your body, everything that you do is because your brain allows you to do it.
Okay. I was curious, do you find that age makes a difference in how someone experiences a stroke, or is it very similar for a young person to an elderly person? Are they describing the same problems the same way?
The experience is the same because the brain has those set responsibilities, but the understanding that the symptoms represent a stroke is a little bit different. So somebody who's younger, when they have a trouble walking, is going to assume that they're having a problem with their leg. They might not recognize that they're at risk for stroke. But stroke can happen to anyone, any age, both genders, every race. Anyone can be affected by stroke.
And that's probably something that is part of the problem, that people when they're younger don't see it and don't recognize it, so they're not as prone to think it necessarily. So.
And young people tend to think that they're invincible.
Yes, that's true. Well, what should someone do if they are having a stroke? And I presume young or old, what is the first thing that usually occurs, and how do they handle that?
The most important thing that should be done is dialing 911, period. any thought in your head that this could be a stroke, whether you're experiencing loss of function yourself or whether you're out about in the community and somebody else suddenly has any symptoms that represent loss of function, dial 911 immediately. And I think the real important question is, why? Why do you need to dial 911? And I think that in our efforts to educate the public, that's what we do least well. We don't explain the why it's important to dial 911. Why should I expect someone to understand that getting treatment in 15 minutes would offer any advantage to getting treatment in 15 days?
Right, and the immediacy, I think, is what is so critical, because only in the past, at least not being in your profession, I guess in the past decade, was that when they were saying that the time with certain drugs and treatments can make a difference, and that was something that it dawned on me.
Well, thank you for bringing that up.
Yeah.
So the two different forms of stroke, the bleeding kind is most of the time caused by really elevated blood pressure. Blood pressure that was so high that it caused the blood vessel to break open. Well, the treatment for that is going to be lowering the blood pressure. And if you're on some type of blood thinner, anticoagulant, there are medications that could reverse the effects of the blood thinner. But the earlier you give that treatment, the less blood there is to cause symptoms. And at some point, you can bleed so much that it could raise the pressure inside the brain and make you not be able to wake up. So the earlier you get treatment for the cause of that form of stroke, the better. And then on the other side, there's the blood clot obstructing blood flow to part of the brain. And brain cells start dying. They start dying pretty quickly. And if you can give a treatment that's designed to open up that blood vessel that's clogged off, either with a clot buster that can be given in an IV, circulate. I like to think of it like Drano for your circulation.
Yes.
You put the medication in, hopefully it finds the clot, hopefully it dissolves the clot, restores blood flow before the brain cells are permanently damaged. And then there's also other treatments that can be provided, like they can for heart vessels. They can go in the first few hours of a brain attack or stroke and take that clot mechanically out with these special devices. But that takes specialized proceduralists too, and not all hospitals have those. But time is critically important. If you get treatment and you get that vessel open within the first hour, you've got a great chance of getting your life back, getting back to normal or very close to normal. But if you wait after a certain period of time, even if you do get the blood vessel open, it doesn't help. If the brain cells are already damaged, then they're damaged, and opening the blood vessel actually could only cause harm, not necessarily any benefit. The time frame for which treatment has been proven to be effective is 4.5 hours from the time of symptom onset. However, you really want to get it in that first hour if you possibly can. Every single minute matters. Up to 2 million brain cells die every single minute during a stroke.
Oh, my
So
goodness.
you don't want to get treated at the tail end. You want to get treated as early as possible.
Right.
And after a certain amount of time, there's less that can be offered to minimize the damage.
And so weakness is something that people shouldn't ignore. Sudden weakness is if that was a sign, immediately don't just assume that, well, I'll wait a little bit. Sudden weakness, it just hit me that is something that someone might not think about.
Any sudden loss of function that you'd kind of like to have back would be a reason to dial 911. Anything that would be disabling would be a reason to dial 911 and get treatment. Even if your symptoms lasted 5 minutes and completely resolved, you're at super high risk of having a stroke in the next 5 minutes.
I see.
And in the next 5 minutes. And with each minute that passes, the likelihood of having a full stroke goes down, but you want to be under the eyeballs of a physician and a nursing team. You want to have access to that clot buster within minutes of recurrence of your symptoms if it should recur. And coming into the hospital, even if your symptoms have resolved completely, affords us the opportunity to look into all the causes of stroke so that we could intervene in ways that reduce the likelihood of having symptoms recur.
Okay. One thing that I know I have heard over my lifetime, should you take an aspirin if you think you are having a stroke? That's something that's been out there as long as I can remember.
It's a great question. Aspirin in the setting of a brain attack has been shown to be effective at minimizing the damage to the heart. The same scenario hasn't been demonstrated to stroke. It doesn't necessarily reduce the damage to the stroke that's happening at that moment. It's a great treatment for prevention of stroke in most people. But in the acute phase, it's not necessarily going to help.
Right.
And guess what? You can't tell, Charlotte, and neither can I, whether someone's having a bleeding kind of stroke, for which that aspirin could actually make you worse, versus having the clotting kind of stroke, for which there's no proven benefit. And another problem with giving aspirin to someone who's having a stroke is about 40 to 50% of people having a stroke actually have trouble swallowing effectively. And if you put anything in their mouth, anything, it could end up in their lungs. And aspirin is an acid. Your lungs don't like aspirin very much. They don't want acid sitting in your lung tissue. It could actually cause an injury to the lungs itself. So you're unlikely to help somebody, and you may actually hurt them because they're either having a bleeding stroke or because they have a risk of getting the aspirin or anything else into their lungs during a stroke. So it's not recommended to do that. Just simply dial 911, grab all the medications, and note the time of onset.
Okay, that's an interesting point. The not being able to swallow is something we don't think about, and you're right. In that kind of case, you're losing function, so everything could be up for a problem. Then, what is done or can be done to treat a stroke?
So one of the things is what I mentioned, that if it was a bleeding kind of stroke, then we are going to aggressively get that blood pressure down so that the pressure on the broken blood vessel is reduced to the point where a clot can form on the surface of that broken blood vessel and stop the bleeding process. Sometimes with a bleeding kind of stroke, we need to get neurosurgeons involved, either to remove the clot itself because it's causing damage to the neighboring parts of the brain, or sometimes the clot can obstruct the normal flow of the fluid that we make, the cerebrospinal fluid, and that can cause an obstruction that needs to be relieved by the placement of a drain. So those are two things that we can do for, and then reversing the blood thinners. If someone's on a blood thinner, reversing that to minimize ongoing bleeding. And then if it's the blockage kind of stroke, the ischemic stroke, what we'll do is if they meet criteria to give the intravenous clot buster, which the name for it, we call it TPA, tissue plasminogen activator. Alteplase is the other name for it. It can be administered into an IV. We can get it into somebody relatively fast from the time that they arrive to the hospital, and it circulates over a period of an hour, and they would need to be admitted to an intensive care unit where they'll be monitored very closely for a period of at least 24 hours to make sure that a complication of the clot buster does not occur, which is bleeding. And if they're eligible for the procedure, that specialized procedure, the angiogram, during which the actual clot can be removed from the obstructed vessel, then they will be referred on for that procedure.
I had one question that just was, because of going to an emergency room, you're having certain symptoms. Do emergency rooms know just almost immediately when someone is having a stroke? Is it that obvious to medical people right away? I was just curious if that's when they walk in and they can say, yep, that's a stroke person.
Well, our pre-hospital providers get specialized training and recognition of stroke, and in my experience, they're really good at it. There's not that many that are missed and get activated once they're in our emergency department. The vast majority are recognized by those pre-hospital providers, and part of the statewide protocol is that if a pre-hospital paramedic or EMT picks up a patient and they screen and they think that the patient might be having a stroke, what they do is they provide pre-hospital notification for the hospital where they're taking the patient so that emergency department knows the patient's coming. So they have a heads up that, in a few minutes we're going to get this person who sounds like they might be having a stroke, then all the steps that are required, and there are several steps required to evaluate whether somebody's a good candidate for getting that clot buster or whether they're having a hemorrhage that needs to be treated, can occur more efficiently. So I hope that answers the question.
Oh yes, I was just curious if it's something that's a very obvious situation, because it is something that they're doing something so fast. Is a stroke a very specific thing that just kind of stands out to people who see it a lot?
But again, a major advantage if you dial 911 and you come in through the emergency department via an ambulance as opposed to a private vehicle. If you come by a private vehicle, the hospital doesn't know you're coming. There's a triage process that you have to rely upon, that your symptoms are obvious enough that you reach detection fast so that the processes all get initiated quickly. And, number one, you may not know which is the most appropriate hospital to go to, but the paramedics do. And also, if you are having the clotting kind of stroke, usually you're pretty stable from the time of onset. But if you are bleeding and you're actively bleeding, you would imagine, and we know that the examination or the patient's neurological status actually declines. The last thing you want to do is have your loved one in the passenger seat of your car as they deteriorate, and you can't do anything to help them.
Right.
Whereas a paramedic, is capable of providing some emergency interventions that will increase the likelihood of surviving and minimize the chances of having major disability.
Okay.
So I strongly recommend 911. Not think that you're going to be faster by coming by private car.
Very good point. That's something I think a lot of people take for granted. Well, we haven't talked about what can be done to prevent a stroke, which is obviously what we should all be after anyway to do. So
that's probably the most important thing to talk about.
That's
because,
true. Yes.
Stroke used to be called a CVA, or cerebrovascular accident. Well, we don't call it that anymore because it's not an accident. Most of the time it's failure of medical management of underlying risk factors. There are risk factors that you can't do anything about. You can't do anything about your age. You can't do anything about your race. You can't do anything about your family history. You can't do anything about your personal history if you've had a stroke. But there are some risks there. I mean, advanced age is the most prevalent risk factor that we have. But of the modifiable risk factors, the conditions that increase the chances of having a stroke that we can actually do something about, is the number one is high blood pressure. High blood pressure, high blood pressure, high blood pressure. It is cause of 90% of the bleeding kind of stroke, and it contributes to about 50% of the clotting form of stroke.
Okay.
So control of high blood pressure through medications if necessary, diet, avoidance of high salt in your diet, exercise is really important to reducing your risk of stroke. And then there's a ton of other risk factors, high cholesterol and smoking, heart disease, atrial fibrillation, which is an abnormal heart rhythm, and that is more common the older we get. Diabetes, obstructive sleep apnea. There's lots of things that you do have within your control to take ownership of to control your risk of having a stroke. And then sometimes there's things like, blockages in a carotid artery that merit opening it up to reduce risk by that mechanism. But most people have many ways that they could invest in their health care to reduce their risk of having a stroke. And it all starts with excellent primary care.
Right, getting people to talk about the different health things they face, especially if they have high blood pressure and they're not wanting to address it, or they want to continue down a path of diet and habit smoking or something that are exacerbating that, and that seems to be something that certainly living in Louisiana and our the way we love to eat and everything, our own recipes contribute to that love of salty food and kind of not addressing those habits as seriously as we should. I guess the next question would be that after someone has had a stroke, even if they are treated early, what kind of physical therapy is very common just for people regaining their life control?
any patient who comes in with a stroke should receive therapy evaluations. And there's essentially three major domains of therapy, and it's speech and language pathology, occupational therapy, and physical therapy. And the simplistic way of thinking about it is, speech and language pathology will evaluate usually on day one to ensure that there is a safe swallowing mechanism. Sometimes it's not safe at all to swallow, and sometimes it's safe for a regular diet, and sometimes that diet needs to be modified in the first days, 2 weeks after a stroke. So that's one aspect. And they also will involve communication and cognition. So the ability to communicate effectively back and forth, have information exchange, be able to express your needs and wants is a really important function. And so they'll work to establish where somebody is in terms of their ability to communicate and help with advancement towards their normal ability to communicate. And then cognition is often influenced by stroke. So establishing a baseline and establishing a plan of care to help thinking and processing and executive functions is important. Occupational therapy is primarily focused on the ability to do things for yourself. It's about your activities of daily living, which is individualized. I mean, yours might be very different than mine, but it's about reestablishing ways to handle things independently. And physical therapy is primarily about mobility, about getting around, being able to transfer, being able to get from point A to point B, being able to get back out into your life. There's different levels of therapy. When somebody's in the hospital, they're going to get evaluated for where they are and where they were and where we anticipate their best version of them will be, and whether or not to achieve that, they should go through intensive therapy in a hospital type setting, or whether it may be more appropriate at a lower level, or whether outpatient or even home health therapy would be ideal to get them to their goals.
Okay. I guess just from taking it back to the age differences, do younger people face different issues than older people as far as long-term recovery is after their therapy? And
the younger you are and the more physically able you are at the time of your stroke, the greater the improvement we anticipate as long as you have access to intensive ongoing therapy. But being able to work is more often affected in the young versus somebody who's already above the average age for stroke, which is 65 in our country. So most of those patients would have already experienced retirement or be planning for retirement. Sure. So the ability to work and provide for your family is a major problem, and many patients aren't going to be able to drive after having a stroke, and so that's loss of independence. And so as a stroke doctor, our goal is to fight for independence and help our patients be aware of stroke and follow my motto, which is always live your life prepared and not scared, but most of all, live your life. So being prepared means taking ownership of the conditions you have that increase your risk and controlling them to the best of your ability through your good relationship with your primary care doctor.
Well, that's all excellent information, and we all need to look at changing our lives to prevent stroke. So thank you so much for coming, and we hope you enjoyed our show, so tune in again real soon.